I want you to imagine your computer running a critical, deep-level software update overnight.
Right.
The system is delicate, the firewalls are temporarily down, and, well, the entire architecture is engaged in essential maintenance. Now, imagine deliberately pulling the power cord out of the wall right in the middle of that process.
It would be catastrophic.
Exactly. That catastrophic system failure is exactly what millions of us are doing to our cardiovascular systems every single night. Welcome to this deep dive.
Thank you. It's a profoundly urgent discussion today.
It really is, because if you are over the age of 60, the most dangerous hours of your life are not when you're driving in heavy traffic or, when you're shoveling snow.
No, not at all.
The most dangerous hours are the ones you spend completely unconscious in your bed. Today, we are conducting a strict medical briefing. We are going to systematically deconstruct the seemingly harmless evening habits that quietly trigger fatal heart attacks and strokes during sleep.
We need to approach this with absolute seriousness.
Yeah.
I mean, most of us operate under the assumption that a cardiovascular event will announce itself with unmistakable, dramatic symptoms.
Right, the classic signs.
Exactly. We expect the severe chest pain, the radiating numbness in the left arm, the sudden shortness of breath. That is what we are conditioned to look for.
But the physiological reality for adults over 60 is entirely different, isn't it?
It is entirely different. The most dangerous cardiac events are the quiet ones. They build slowly in the dark. They offer no warning signs, they allow no time to call for emergency services, and, well, they provide no second chances.
And the crucial realization we must confront today is that these fatal events are almost exclusively triggered by ordinary routines. Completely unremarkable habits that you perform in the hours immediately preceding your sleep.
Yes. To establish the sheer scale of this crisis, we have to look at the foundational clinical evidence. We're not talking about isolated incidents here.
Let's look at that landmark 9-year study published in the European Heart Journal. This was a massive undertaking. They tracked over 84,000 adults, specifically focusing on the demographic between the ages of 60 and 80. And the data they uncovered revealed a staggering reality.
The numbers are deeply concerning.
Individuals who followed specific, what we would call dangerous nighttime routines, faced a 67% higher risk of dying from a sleep-related cardiac event.
Compared to those who optimize their evenings, yes.
I want to pause and emphasize that number. A 67% increase in your risk of mortality, based entirely on how you conduct yourself in the 2 to 3 hours before your head hits the pillow.
To understand the gravity of that 67% increase, you have to completely reframe how you view sleep.
How so?
Sleep is not merely a cessation of consciousness. It is not an off switch. It is an incredibly active, vital, and complex biological maintenance protocol.
Right.
In a healthy younger body, the transition into sleep signals your autonomic nervous system to execute a massive shift. It forcefully downregulates your sympathetic nervous system.
Which is your fight or flight drive, right? The system that keeps you alert during the day.
Precisely. And simultaneously, it upregulates your parasympathetic nervous system, which is your rest and digest mechanism.
So we're talking about a systemic shift in chemical commands.
Exactly. This shift commands the heart rate to slow down significantly, but it goes much deeper than just heart rate. The endothelial cells, which are the delicate cells lining the inside of all your blood vessels, they receive chemical signals to release nitric oxide.
And what does that do mechanically?
It induces vasodilation, meaning your blood vessels physically widen and relax. Because the pipes are wider and the pump is working slower, your systemic blood pressure naturally dips by 10 to 20%.
In clinical cardiology, we call this phenomenon nocturnal dipping.
Yes, it is a profound biological reset. It's the only true rest your cardiovascular system receives in a 24-hour cycle, and it is absolutely essential to relieve the sheer mechanical stress placed on the heart and the vessel walls throughout your waking hours.
But the critical point we need to make today is that this highly efficient reset mechanism is heavily dependent on youth.
Unfortunately, yes.
As your body ages past 60, that biological machinery begins to degrade. It is an unavoidable reality of human aging. Your arterial walls lose their elasticity.
They become stiffer due to decades of gradual calcification and microscopic plaque buildup.
Furthermore, your baroreceptors, which are the microscopic sensors embedded in your blood vessels that constantly measure and regulate your blood pressure, they become significantly less precise.
They don't respond as quickly or as accurately to the demands of the nervous system.
And the hormonal signals that once actively protected your heart during this nocturnal shift begin to weaken. So the protective margin for error essentially vanishes.
That is the exact mechanism of vulnerability. During your waking hours, even if you are over 65 or 70, your cardiovascular system still possesses active, conscious backup mechanism.
Right, you can compensate.
Exactly. You can compensate for physiological stress through movement, through varied breathing patterns, and through conscious regulation. But during sleep, every single one of those compensatory mechanisms goes offline.
Your body is forced to operate on a biological skeleton crew.
That is the fundamental reason why the hours between midnight and 6 in the morning become the absolute most perilous time for the aging cardiovascular system. Your body is attempting to perform a highly delicate maintenance cycle using degraded equipment and zero redundancies.
Therefore, what dictates whether your heart safely survives that nightly maintenance cycle is entirely dependent on the physical and chemical state you force your body into right before going to bed.
Which brings us to the first major threat on our list.
Yes, because your nighttime cardiovascular system is operating on that skeleton crew, we have to examine what we call the hemodynamic conflict of late digestion.
The concept is straightforward but deadly.
Forcing your body into a state of heavy physiological labor, while simultaneously expecting it to perform a delicate cardiovascular reset is, well, mathematically and biologically impossible. We are specifically talking about the incredibly common habit of eating a large, heavy meal late in the evening.
It is arguably one of the most common routines in modern society. Patients frequently consume their largest, most calorically dense meal of the day at 7, 8, or even 9 o'clock at night.
Followed shortly by sitting in a recliner and then lying down to sleep.
From a strictly clinical cardiology perspective, subjecting your body to a heavy meal late at night is one of the most severe, consistently underestimated mechanical stresses the aging heart can face.
Let's unpack the clinical data supporting this because the numbers are alarming. Researchers at the University of São Paulo conducted a rigorous study looking specifically at this exact behavior.
And what did they find?
They demonstrated that in adults over the age of 65, consuming a large meal late in the evening increases blood pressure by an average of 22 points.
22 points is a massive spike.
Furthermore, it keeps the heart rate significantly elevated for up to 3 hours after you finish eating. So if you eat at 8, your heart is racing until 11.
I want us to break down the exact biological mechanism behind this hemodynamic conflict. Why does the seemingly simple, natural act of digesting a meal cause such a violent cardiovascular disruption when you are trying to sleep?
The mechanism is entirely mechanical and circulatory. Digestion is not a passive process.
No, it is incredibly labor-intensive. When you consume a large meal, your digestive system requires an enormous, immediate surge of localized blood flow to what we call the splanchnic circulation.
Which is the vast network of blood vessels supplying your stomach, your liver, and your intestines.
Right. It needs this massive volume of blood to physically extract, process, and transport the nutrients you just ate. But that blood has to come from somewhere, and the pressure has to be generated by the pump.
Meaning the heart.
To deliver that massive volume of blood to your gut, your heart must dramatically increase its cardiac output. It is forced to pump much harder and much faster.
So your heart is behaving as if you were taking a bar walk, even though you were sitting entirely still.
Exactly. And simultaneously, the actual absorption of the meal causes your triglycerides, which are the fats present in your blood, to spike sharply within 2 to 4 hours after eating.
So consider the intense biological conflict you have just created in your body.
You finish your meal, go to bed, and you lie down. By lying down and closing your eyes, you are commanding your autonomic nervous system to execute that crucial 10 to 20% pressure dip we discussed earlier.
You are telling the system to shut down for maintenance.
But at the exact same moment, your digestive tract is screaming for maximum blood flow. The heart is working overtime to fuel the digestion of that steak or pasta, while the nervous system is simultaneously attempting to forcibly shut down the cardiovascular output.
You are sending your heart completely contradictory commands. It is exactly like forcing a complex engine into a high-revving, heavy-load state, while at the exact same time initiating the total shutdown procedure for overnight maintenance.
The system is going to tear itself apart, trying to obey both commands.
But beyond the sheer pumping demand, we have to look at the secondary threat here, which involves the vagal nerve and its connection to acid reflux.
This is critical.
As we age past 70, the lower esophageal sphincter, which is the muscular valve that keeps your stomach acid from entering your esophagus, weakens considerably. When you lie completely flat with a stomach fully engorged with a recent meal, that highly corrosive acid easily escapes upward.
Most people view heartburn as just an uncomfortable annoyance.
But how does this specific gastrointestinal issue translate into a potentially fatal cardiac rhythm?
That is an anatomical connection that is almost never adequately explained to patients. The esophagus, the tube that carries your food, and your heart reside in extremely close physical proximity to each other within the chest cavity.
Right next to each other.
More importantly, both of these organs are heavily innervated by the vagus nerve. The vagus nerve is the primary superhighway of your parasympathetic nervous system. It's the major nerve responsible for regulating your heart rate.
Okay, so how does the acid affect the nerve?
When highly acidic stomach contents wash back up and severely burn and irritate the lining of the esophagus due to reflux, it strongly stimulates that vagus nerve. In a 25-year-old, this intense stimulation might just cause intense discomfort and maybe a slight flutter in the chest.
But in an older adult?
Particularly an adult over 65 who may have underlying ischemic heart disease or early-stage arterial stiffness or any pre-existing electrical instability in the heart. This intense, sudden vagal stimulation acts quite literally like a sudden electrical shock to the cardiac conduction system.
So the acid burn in the throat is sending a chaotic electrical signal straight to the pacemaker of the heart.
Precisely. It can, and it frequently does, trigger highly irregular, potentially fatal heart rhythms directly out of a deep sleep.
We are talking about triggering sudden onset atrial fibrillation, or AFib, where the upper chambers of the heart begin to quiver chaotically instead of beating effectively.
Which causes blood to pool in the heart.
And that pooling can immediately form a clot, which is then pumped directly to the brain, causing a massive stroke. All initiated because the patient lay down with a full stomach.
Therefore, the clinical protocol to avoid this hemodynamic conflict is absolutely non-negotiable for anyone over 60. The main, nutrient-dense meal of your day must be completely finished by 6, or, at the absolute latest, 7 o'clock in the evening.
If you genuinely require late-night sustenance due to specific metabolic issues or diabetic needs, the intervention must be minimal and extremely easy to digest.
We are talking about half a banana or a very small handful of walnuts, nothing that requires a massive diversion of blood to process.
And crucially, we must implement a mechanical intervention immediately post-dinner. Pairing your evening meal with a deliberate 10-minute walk is mandatory.
Research from the University of Limerick conclusively proves that just 10 minutes of light walking after a meal reduces blood sugar spikes by an incredible 28%.
It mechanically assists your stomach in emptying its contents into the small intestine much faster, which drastically reduces the digestive burden placed on your heart before you attempt to sleep.
The biomechanics of that 10-minute walk are brilliant in their simplicity. When you walk, you utilize the large skeletal muscles of your legs. These muscles act as a powerful secondary pump for your circulatory system.
As the leg muscles contract, they forcefully squeeze the veins,
Aiding venous return, meaning they help push the blood back up to the heart. You are essentially allowing your leg muscles to share the circulatory workload with your heart during the peak intensity of digestion.
It is a profoundly effective, entirely free, non-pharmacological intervention that physically prepares your cardiovascular system for a safe transition into the nocturnal state.
So, we have established that a full stomach essentially hijacks the blood supply and risks short-circuiting the heart. But even if you perfectly execute the dinner protocol, even if you go to bed on an empty stomach, if the blood itself isn't physically prepared correctly, you are still walking blindly into a trap.
Moving from the mechanical stress of digestion, we have to look at the actual consistency and physical state of the blood itself. This brings us to a highly logical, incredibly widespread, but lethally dangerous senior habit.
Nocturnal fluid restriction.
Yes. This is the silent dehydration trap.
This specific habit is a textbook example of a well-intentioned patient attempting to solve one legitimate problem while inadvertently creating a lethal vulnerability.
The root cause of this behavior makes perfect sense. As we age, we want to sleep through the night.
Millions of older adults deliberately stop consuming any water or fluids in the mid to late afternoon. Their stated objective is to prevent nocturia, which is the medical term for waking up multiple times in the night to urinate.
By intentionally dehydrating themselves and eliminating those bathroom trips, they aim to preserve unbroken sleep. And crucially, they are trying to significantly reduce the risk of suffering a catastrophic fall, like a hip fracture, while navigating a dark hallway at 2 in the morning.
The logic is sound on the surface. Falling is a massive risk. But the underlying biology of what happens when you restrict fluids compounds into an absolute crisis. We have to factor in the reality of the aging renal system.
As you age, your kidneys naturally lose their efficiency in concentrating urine.
Right. This means your body is forced to excrete a higher volume of water just to clear the exact same amount of daily waste. So you're already losing water faster than you did in your 30s.
Furthermore, clinical data from the University of Connecticut demonstrates a terrifying neurological shift. The hypothalamus, which is the specific region of your brain responsible for generating the sensation of thirst, blunts significantly after the age of 60.
It stops sending the signal.
This creates a highly dangerous physiological reality. If you are over 60, you are routinely operating in a state of severe clinical dehydration without ever consciously registering the physical sensation of feeling thirsty. You cannot trust your sense of thirst.
So what are the specific localized consequences to the cardiovascular system when you enter the 8-hour sleep cycle in a deliberately dehydrated state?
The direct consequence is a drastic, dangerous alteration in your blood viscosity. We need to visualize what blood actually is.
Blood is a suspension. It is comprised of plasma, which is the liquid portion that is primarily made of water, and it contains solid cellular components like red blood cells and platelets.
When you deliberately restrict fluids and become dehydrated, your plasma volume drops significantly because your body lacks water. However, the solid cellular components, the red blood cells and the sticky platelets, do not drop.
They're made at the exact same volume. Therefore, the blood literally becomes thicker. It becomes highly viscous, dense, and vastly more prone to rapid coagulation.
A definitive study published in the American Journal of Epidemiology presents a truly chilling finding for this demographic. Adults over the age of 65 who exhibit even mild clinical dehydration at bedtime demonstrate blood viscosity levels that perfectly match the blood viscosity levels seen in patients immediately prior to suffering an ischemic stroke.
Let's visualize the mechanical burden you are placing on your heart when this happens. It is the middle of the night. Your heart rate is naturally functioning at its absolute lowest, slowest pace of the entire day.
Your arterial pathways are naturally narrowed and stiffened by decades of accumulated plaque and calcification.
And now, due to your intentional choice to stop drinking water at 3 in the afternoon, the fluid being pushed through this highly compromised, slow-moving system is no longer flowing freely like water.
It is thick, dense, and sticky. It is the exact physiological equivalent of attempting to pump thick, cold motor oil through narrow, heavily calcified pipes using a pump that is operating at incredibly low pressure.
The physical friction against the inner vessel walls increases exponentially. And because the flow is so sluggish and the fluid is so thick, the probability of those red blood cells and platelets clumping together in the slow current to form a deadly thrombus, a massive blood clot, reaches its absolute peak.
That is the precise mechanism of mortality. And that clot, depending entirely on where it forms and where the sluggish current eventually carries it, dictates the fatal pathology.
If that clot lodges in a narrowed coronary artery supplying the heart muscle, it causes an acute myocardial infarction, a massive heart attack.
If that clot travels upwards into the cerebral vasculature of the brain, it causes an acute ischemic stroke.
This highly toxic combination of naturally slow nocturnal circulation, pre-existing arterial stiffness, and artificially induced high blood viscosity is the precise, undeniable physiological reason why the vast majority of fatal strokes and heart attacks cluster in the early morning hours right before waking.
The blood simply becomes too thick to move through the compromised pipes.
This presents a profound, highly practical clinical challenge for you listening right now. How do you balance the absolute physiological necessity of fluid intake to keep your blood flowing against the very real, immediate physical danger of breaking a femur or a hip during a groggy 2 a.m. trip to the bathroom?
You cannot ignore the fall risk, but you cannot allow your blood to turn to sludge. The solution requires precise biological targeting. It is not just about drinking massive amounts of random water before bed.
Exactly. The clinical protocol must be exact and scientifically sound. We absolutely do not advise drinking large volumes of plain water immediately before laying down. That will guarantee nocturia and increase your fall risk.
The protocol is to consume exactly 8 ounces of water, 1 standard glass, 2 full hours before your intended sleep time. But crucially, this cannot just be tap water. It must be integrated with specific electrolytes, explicitly potassium and magnesium.
This is where we leverage what we call dietary pharmacology. Let's break down exactly how this works. By consuming potassium-rich foods in the late afternoon, we highly recommend a small baked sweet potato, or a serving of dried apricots. You fundamentally alter your body's cellular osmotic balance.
Potassium acts like a biological magnet for water.
It pulls the water you drink directly into the intracellular space, meaning it hydrates the actual cells of your body directly. If you just drink plain water, it stays in the extracellular fluid where it is very quickly filtered by the kidneys and dumped straight into your bladder, waking you up at 2 a.m.
But by introducing potassium, the water is retained exactly where it is needed to maintain healthy blood volume and prevent that thick motor oil viscosity without aggressively filling the bladder and forcing a nighttime waking.
Additionally, the inclusion of magnesium serves a vital dual purpose in this protocol. First, it actively assists in that intracellular hydration matrix we just discussed.
But more importantly, from a cardiovascular perspective, magnesium acts as a potent natural calcium channel blocker.
Once it enters your system, it actively targets and relaxes the smooth muscle tissue lining your arterial walls. It promotes vasodilation, forcing the pipes to widen.
This directly and mechanically counters the friction caused by any remaining blood viscosity. It is a highly protective, scientifically proven, two-pronged defense mechanism.
You maintain blood fluidity with the potassium-bound water, and you widen the vessels with the magnesium, drastically lowering your risk of a nocturnal clotting event.
So we have carefully managed the digestive workload with an early, light meal, and we have chemically optimized your blood viscosity through precise electrolyte-bound hydration. But even with an empty stomach and perfectly flowing blood, your body remains deeply vulnerable to external physical factors.
We must now examine the environmental and positional obstructions to cardiovascular rest. The physical geometry of your airway as you sleep and the ambient temperature of your bedroom can instantly force your entire cardiovascular system into a state of absolute emergency.
Let's address thermoregulation first, because it is entirely within your control, yet it is almost universally misunderstood and mismanaged by older adults.
Human biology demands a very precise, narrow temperature window to achieve restorative sleep and maintain cardiovascular safety. We frequently see senior patients sleeping in environments exceeding 22 degrees Celsius or roughly 72 degrees Fahrenheit, often using heavy blankets or electric heaters because they feel the cold more acutely.
When your sleeping environment exceeds this temperature, your body perceives a deep biological threat of hyperthermia.
To dissipate that excess heat and protect your core organs, your autonomic nervous system forces extreme vasodilation near the skin surface and initiates sweating.
This rapidly and aggressively accelerates the severe dehydration and blood viscosity crisis we just discussed. You are literally sweating out your blood volume.
Furthermore, your heart rate remains chronically elevated all night long as the heart is forced to continuously pump blood to the surface of the skin to cool it down.
Conversely, we see the opposite trend, which presents a completely different mechanism of vascular injury. Many people believe sleeping in a deeply chilled room is better for sleep architecture.
But a room maintained under 16 degrees Celsius, or roughly 60 degrees Fahrenheit, forces severe peripheral vasoconstriction. Your blood vessels tighten aggressively to preserve your core body heat.
This is a mechanical tightening that violently elevates your systemic blood pressure. Your aging heart is suddenly forced to pump against massive physical resistance all night.
Therefore, the strict clinical recommendation, firmly grounded in vascular mechanics, is maintaining a neutral ambient temperature precisely between 18 and 22 degrees Celsius or 65 to 72 degrees Fahrenheit.
This specific thermal window completely eliminates thermoregulatory stress. It stops you from sweating out your blood volume, and it stops your vessels from clamping down, fully protecting your vascular system.
But the thermal environment is only one physical constraint. We must urgently transition to the geometry of your airway, specifically the profound, life-threatening danger of positional asphyxia caused by the simple habit of sleeping on your back.
When you lie completely supine on a mattress, gravity acts directly and mercilessly on the relaxed musculature of your tongue and the soft tissues of your pharynx, your throat.
In older adults, the natural tissue elasticity in the airway is already heavily diminished. Gravity quite literally pulls these relaxed tissues downward, causing them to physically collapse and block the upper airway.
Which leads us directly to the critical, widely ignored epidemic of obstructive sleep apnea. The clinical data on this is terrifying. Studies indicate that a full 50% of adults over the age of 65 suffer from some degree of obstructive sleep apnea.
Half the senior population.
This leads to incredibly dangerous, repeated drops in blood oxygen saturation throughout the night. I want us to trace the exact chemical cascade of an apnea event. What exactly is happening neurologically and cardiovascularly to a patient when that airway collapses?
We need to stop thinking of sleep apnea as just heavy breathing. It is a violent physiological trauma. When that soft tissue collapses and blocks the airway, you essentially stop breathing entirely.
Within seconds, the oxygen saturation in your blood plummets and your carbon dioxide levels begin to rapidly rise.
The chemoreceptors in your brain, your internal chemical alarms, register this severe hypoxia as an acute life-threatening crisis. Your brain truly believes you are choking to death.
To save your life, the brain reacts by flooding your central nervous system with massive, instantaneous surges of cortisol, epinephrine, and norepinephrine. These are your primary, most potent stress and survival hormones.
These chemicals aggressively and violently spike your heart rate and force extreme systemic vasoconstriction. They send your blood pressure soaring to catastrophic stroke-level heights in a desperate physiological attempt to force whatever oxygenated blood is left to your brain and vital organs.
Your heart is literally jolted awake, violently accelerating and pounding against immense pressure, while your physical body remains entirely paralyzed and unconscious in the bed.
Societally, we have a deeply dangerous tendency to view snoring, which is the primary audible symptom of this airway collapse, as a benign, almost humorous annoyance. We complain about our spouses snoring, we wear earplugs.
We must strictly and immediately reframe this. An apnea episode is not an annoyance. It is a literal microsuffocation event. It is a recurring physiological crisis that repeatedly electroshocks your nervous system dozens, sometimes hundreds of times every single night.
A definitive landmark study published in the journal Circulation conclusively proves that adults with moderate to severe obstructive sleep apnea carry a staggering 58% higher risk of experiencing a fatal cardiac rhythm during sleep.
58%. If you are listening to this and you snore heavily or wake up gasping, your heart is sustaining massive damage every night. How quickly does clinical intervention, specifically CPAP therapy, reverse this specific vascular damage?
The reversal is remarkable, provided the patient complies strictly with therapy. A continuous positive airway pressure, or CPAP machine, is not a cure for the tissue weakness, but it acts as a flawless pneumatic splint.
It forces a gentle, continuous stream of pressurized room air down your throat, mechanically preventing that soft tissue from collapsing under the weight of gravity.
When the airway remains physically open, the hypoxic choking crises completely stop. The massive surges of cortisol and adrenaline cease instantly.
Clinical data definitively shows that within mere weeks of consistent CPAP use, the patient's nocturnal blood pressure drops significantly back to normal levels. The catastrophic risk of triggering atrial fibrillation is massively reduced, and the sheer physical strain on the heart muscle is profoundly alleviated.
It is one of the most effective cardiovascular interventions in modern medicine.
Now, for those of you who may be awaiting a formal sleep study or are currently untreated, the immediate mandatory clinical protocol tonight is positional modification. You must cease back sleeping entirely.
The directive is to sleep on your side, and we specifically recommend the left side.
Sleeping on your left side anatomically reduces direct mechanical pressure from your internal organs onto the inferior vena cava, which is the massive vein returning blood to your heart. This optimizes venous blood return and reduces cardiac strain.
Utilizing a firm body pillow tucked behind your back to physically block you from rolling onto your back while unconscious is a mandatory, highly effective, non-pharmacological intervention.
But you must demand a clinical sleep study from your primary care physician to evaluate your need for a CPAP.
Having comprehensively addressed the physical inputs, the digestion, the fluid dynamics, the ambient temperature, and the physical geometry of your airway, we must now pivot to examine the pharmacological interventions that millions of patients rely upon to survive.
The most devastating cardiovascular failures in the middle of the night often occur not because a patient lacks the proper medicine, but because of a catastrophic, easily preventable error in its daily application. We are talking about the pharmacological misalignment that results in deadly nocturnal hypertension.
The clinical reality is immense. Nearly 60% of all individuals over the age of 60 are prescribed daily medication to manage high blood pressure.
Yet, an overwhelming majority of these patients take this vital, life-saving medication in the morning, immediately upon waking up, usually alongside their breakfast or coffee, purely by default or force of habit.
And taking that medication in the morning represents a fundamental, highly dangerous misunderstanding of human chronobiology. As we discussed in depth earlier, a healthy cardiovascular system naturally drops its blood pressure by 10 to 20% at night.
However, a massive subset of seniors, particularly those with existing diagnosed hypertension, experience a complete reversal of this healthy biological pattern.
They do not experience the nocturnal dip. Instead, their blood pressure remains highly elevated all night long, or worse, it surges violently and uncontrollably in the early morning hours, specifically in that critical, highly dangerous window between 3 and 6 a.m.
This phenomenon is the clinical definition of nocturnal hypertension, and it is a massive driver of mortality.
Let's analyze the exact physical vulnerability here. Why is a blood pressure spike at 4 in the morning so much more deadly than a spike at 4 in the afternoon?
During the day, the smooth muscle of your arterial walls is somewhat primed. It is chemically and physically braced for the fluctuations of daily physical stress, movement, and emotional reactions.
But during deep sleep, your arterial walls are fully relaxed, attempting to execute their quiet maintenance cycle. If an unchecked, massive blood pressure surge hits your system at 4 in the morning, it hits vulnerable, highly relaxed, completely unbraced arterial walls.
The sheer, sudden hemodynamic force of that pressure wave is exponentially more likely to physically rupture a vulnerable calcified plaque deposit inside a coronary artery or a cerebral artery, causing an immediate heart attack or stroke.
Exactly. And this is precisely where the timing error of your medication becomes fatal. If a patient takes their standard antihypertensive medication at 8 in the morning, the drug enters the bloodstream and reaches its absolute peak plasma concentration by midday.
It does its job while you're awake.
But by the time you go to sleep at 10 or 11 at night, that drug is already being actively metabolized and excreted by your liver and kidneys. By 3 in the morning, the exact moment when you are at maximum physiological risk for a deadly pressure surge and a subsequent plaque rupture, the medication has completely worn off.
It is entirely gone from your system. The patient is left metabolically naked and entirely defenseless against the greatest threat of the 24-hour cycle.
Think of it like hiring an elite, highly trained security guard to protect a bank vault, but mandating that the guard clock out and leave the premises at 3 a.m. when you know for an absolute clinical fact that the bank robbers historically arrive at 4 a.m.
It makes zero logical sense, yet millions of people do this to their hearts every morning. To prove just how deadly this timing error is, we look to the landmark Hygia chronotherapy trial. This was not a small observational study.
This trial followed an astonishing 19,000 hypertensive patients over a period of 6 full years. The clinical data they produced is absolute, rigorous, and completely undeniable.
Simply shifting the exact same dose of blood pressure medication from the morning to the evening right before bedtime resulted in a 45% lower risk of acute myocardial infarction, a 49% lower risk of heart failure, and a staggering 66% lower risk of ischemic stroke.
You have to understand, in the field of preventative cardiology, those numbers are not just marginal, incremental improvements. They represent a fundamental, earth-shattering paradigm shift.
A 66% reduction in stroke risk simply by changing the hour you swallow a pill.
By ensuring that the peak drug concentration in your bloodstream aligns perfectly with your peak physiological vulnerability at 4 in the morning, we chemically stabilize and reinforce the arterial walls during the exact window when they're most statistically likely to fail.
Hearing a statistic like a 66% reduction in strokes immediately raises a vital, highly frustrating question for anyone listening. If the data is this absolute, why isn't this life-saving chronological adjustment the universal, mandatory standard of care in every single medical clinic in the world?
The slow adoption is largely due to medical inertia and the complex realities of individual patient variants. Historically, medication compliance is much higher when patients take all their pills in the morning as part of a fixed routine.
Doctors genuinely fear that if they move medications to the evening, patients will simply forget to take them, which is also dangerous.
Furthermore, many common antihypertensive medications include a diuretic component, a water pill. If a patient takes a diuretic right before bed, it will drastically exacerbate the nocturia and dehydration cycle we discussed earlier, forcing them out of bed multiple times a night.
There are also specific, complex classes of cardiovascular medications that must be timed with food absorption or spaced away from other drugs.
Which brings us to the absolute mandatory caveat of this entire briefing. You must listen to this carefully.
No patient, under any circumstance whatsoever, should arbitrarily shift the timing of their cardiovascular medication based on a deep dive or a broadcast.
The physiological dynamics of blood pressure regulation, drug half-lives, and chemical interactions are vastly too complex for you to manage on your own. You cannot simply decide to take your morning pill tonight.
However, this clinical data must be utilized to empower you. You must use this information to prompt a specific, rigorous consultation with your prescribing physician or cardiologist.
You must explicitly ask them, does my specific pharmacological profile and the specific drugs I am on support evening chronotherapy?
It is a vital, potentially life-saving discussion, but it is a discussion that must occur in a clinical setting under strict medical supervision.
Having firmly secured the mechanical baselines of digestion, fluid dynamics, environmental temperature, airway geometry, and pharmacological timing, we must now pivot our focus from the blood vessels directly to the brain.
We must analyze how our modern, seemingly harmless neurological habits actively and chemically strip the heart of its natural endogenous overnight armor. We're addressing the severe neurological sabotage caused by artificial blue light and the subsequent depletion of melatonin.
We must confront the clinical reality of seniors bringing modern technology directly into the sleep environment. The prevalent, almost universal habit of scrolling through tablets, smartphones, and heavily backlit e-readers in bed is ubiquitous.
Everyone does it to wind down. But consider the clinical case study of a 78-year-old patient who presented to a neurology ward with recurrent ischemic strokes.
This patient maintained otherwise pristine health markers. They had a proper Mediterranean diet, they were at their ideal weight, and they had excellent adherence to their morning and evening medications.
The invisible, highly destructive variable that was completely missed for months was the patient's daily routine of utilizing a brightly illuminated tablet held mere inches from their face for 2 hours immediately preceding sleep every single night.
To comprehend why reading on an iPad can trigger a stroke, we must completely redefine our biological understanding of what melatonin actually is.
The general public, and frankly a significant portion of medical practitioners, view melatonin exclusively as a sleep-inducing hormone.
They view it as a simple, mild chemical switch that regulates drowsiness, something you buy in a gummy form at the pharmacy to help with jet lag.
This is a severe, dangerous underestimation of its profound biological utility. Extensive, rigorous research originating from Brigham and Women's Hospital conclusively proves that melatonin is, in fact, a deeply potent systemic antioxidant.
Its primary critical biological function is not just making you sleepy, it is the active overnight maintenance, repair, and protection of the endothelium, which is the incredibly delicate, single-cell thick inner lining of all your blood vessels.
This is a massive paradigm shift. I want to underline this heavily. Melatonin must be conceptualized not merely as a benign sleep aid, but as systemic vascular armor.
Every day, your blood vessels sustain microscopic damage and oxidative stress. Think of it like microscopic rust forming on the inside of a pipe.
When melatonin is naturally released into your bloodstream at night, it actively scavenges and neutralizes the free radicals causing that rust.
It forcefully suppresses inflammatory cytokines, and it meticulously protects the arterial walls from the specific oxidative damage that directly accelerates plaque buildup, arterial stiffening, and the eventual fatal rupture of that plaque.
If you do not have melatonin, your blood vessels are quietly rusting and weakening all night long.
And here's the compounding deficit that absolutely devastates older adults. As the human brain ages, the pineal gland, the tiny structure deep in the brain responsible for manufacturing melatonin, naturally calcifies and degrades.
It is an unavoidable part of aging. By the time an adult reaches the age of 70, their baseline natural endogenous production of melatonin has dropped by an astonishing 75% compared to when they were 25 years old.
The senior cardiovascular system is already operating with a severely depleted, critically low reserve of this vital vascular armor.
Now, add the technology into the mix. When that 70-year-old patient lies in a dark room and stares into a backlit tablet, the highly concentrated short-wavelength blue light emitted from that screen strikes the photoreceptors in the retina of the eye.
The optic nerve instantly transmits a powerful electrical signal directly to the suprachiasmatic nucleus in the brain, chemically simulating high noon.
The brain thinks the sun is blazing in the sky. As a direct result, the pineal gland instantly and completely halts whatever minuscule remaining production of melatonin it had managed to initiate.
By simply reading the news on a tablet in bed, the patient is systematically, photochemically eradicating their last remaining cardiovascular defense mechanisms.
A deeply concerning study published in the Journal of the American College of Cardiology directly links this specific chronic nighttime light exposure to a 43% increase in major adverse cardiac events in older adults. Reading on a screen is actively destroying your heart's ability to repair itself.
We can trace the exact, measurable physiological link between the elimination of that screen time and the subsequent repair of the cardiovascular system.
In clinical cases where strict zero-screen curfews are enforced for patients, we consistently observe a rapid 30% drop in C-reactive protein, or CRP, in their blood work.
CRP is the primary, globally recognized blood marker for severe systemic inflammation. Without the harsh blue light suppressing the system, the pineal gland is allowed to synthesize its maximum, albeit age-reduced, capacity of melatonin.
This endogenous melatonin enters the bloodstream, physically binds to receptors on the endothelial cells, and chemically neutralizes the oxidative damage occurring along the arterial walls.
The localized inflammation drops, the systemic CRP levels plummet, and the risk of a vulnerable plaque rupturing in the middle of the night is massively mitigated.
Therefore, the clinical protocol regarding technology is absolute and uncompromising. There must be a strict zero-screen policy enforced for a minimum of 2 full hours prior to your intended sleep time.
Televisions in the bedroom, illuminated tablets, smartphones, and backlit e-readers must be physically removed from the environment or powered down completely.
If you want to read, you must read a physical paper book using a warm-tone, dim bedside lamp. This is not a gentle recommendation for better sleep hygiene. It is a required, non-negotiable medical intervention to preserve your endogenous vascular protection and stop your arteries from degrading overnight.
Which brings us to our final and undeniably most critical segment of this briefing. We have established highly rigorous, scientifically backed protocols for your digestion, your hydration, your airway protection, your pharmacology, and your photochemistry.
But we must now address the singular, overarching factor that possesses the systemic physiological power to instantly override every single one of those protective measures we just built. We must confront the ultimate, invisible threat, your psychological state before sleep.
Specifically, the devastating physiological impact of chronic evening rumination.
The physiological mechanism of psychological stress is paramount here. We cannot separate the mind from the heart. Consider the deeply ingrained daily habits of countless older adults. Sitting in the living room consuming aggressive, highly confrontational, high-conflict political news broadcasts at 9 or 10 o'clock at night.
Or turning off the lights and lying awake silently obsessing and worrying about fixed income finances, declining physical health, or deep familial conflicts.
We must understand that this is not merely an emotional burden or a bad mood. This is a highly destructive, chemically measurable physiological trigger.
Researchers at the University of California, Berkeley define this specific, repetitive cognitive loop as rumination. From a strict biological standpoint, when your brain engages in deep rumination, when you are agonizing over a political broadcast or a financial fear, the amygdala, which is the brain's primal threat processing center, engages.
And the crucial flaw in human biology is that the amygdala cannot distinguish between a perceived abstract financial threat and an immediate physical predator standing in your bedroom.
It registers threat and responds identically. It instantly commands your adrenal glands to initiate a massive, sustained release of cortisol and adrenaline into your bloodstream.
This sustained chemical stress acts as a total systemic software override. We spent a significant amount of time discussing the critical 10 to 20% nocturnal blood pressure dip that is absolutely required for cardiovascular maintenance.
Chronic evening stress entirely blocks that parasympathetic shift. It overrides the command.
The biological hardware, your heart and your fragile blood vessels, is completely and forcefully prevented from entering its required maintenance mode because your neurological software is locked in a state of high alert survival.
You are demanding your heart to prepare to fight or run, while forcing your body to lie perfectly still in the dark.
And the physical damage is exponential for older adults. After the age of 70, the human body's endocrine system drastically loses its metabolic efficiency in clearing cortisol from the bloodstream.
Your biological ability to regulate, metabolize, and lower circulating cortisol is reduced by roughly 40% compared to your youth.
Therefore, an evening spike in stress hormones triggered by a news broadcast doesn't just dissipate an hour after you turn off the TV or finally fall asleep. Because your clearing mechanism is degraded, that massive dose of cortisol circulates toxically and relentlessly throughout your entire cardiovascular system all night long.
It keeps your blood pressure elevated, your heart rate rapid, and your vessels constricted for 8 solid hours of intended rest.
The clinical data validating this psychological threat is genuinely terrifying. A comprehensive, highly rigorous 20-year longitudinal study conducted jointly by the American Heart Association and Johns Hopkins University focused specifically on these psychological states.
They didn't just ask people if they were stressed, they tracked their outcomes for 2 decades.
The conclusion was undeniable and grim. Adults who engaged in chronic nighttime worry and maintained high evening stress levels faced a staggering 72% higher lifetime risk of suffering a fatal heart event compared to their peers who actively managed and neutralized their pre-sleep psychology.
Worrying in bed is literally killing people at a massive statistical rate.
The clinical challenge here is immense. As medical professionals, we cannot simply instruct a senior patient who is facing genuine, highly valid, late-in-life anxieties regarding their mortality, their spouse's survival, or their financial independence to just stop worrying.
That is useless advice. The intervention must be mechanical and pharmacological. We have to give the patient the tools to forcefully and mechanically shut off the biological cortisol production, regardless of what they're feeling emotionally.
The protocol to achieve this requires a dedicated, intentional 30-minute cardiac wind-down routine. It must be treated with the exact same seriousness as taking a prescription pill.
First, we implement a highly specific mechanical respiratory intervention, the 4-7-8 breathing technique.
You inhale deeply through the nose for 4 seconds. You hold that breath securely in your lungs for 7 seconds, and you exhale forcefully through pursed lips for 8 full seconds. You repeat the cycle 4 times.
This specific, mathematically precise ratio is not meditation. It is a biomechanical hack. It artificially and physically manipulates the vagus nerve in your chest, forcefully activating the parasympathetic nervous system and mechanically halting the adrenal glands from releasing any more adrenaline.
Next, we implement a cognitive interruption. You take a physical pen and paper and write down 3 positive occurrences from your day, no matter how small.
The act of writing forces your prefrontal cortex, the logical part of your brain, to engage and physically override the amygdala's emotional threat loop.
UC Berkeley clinical data proves that this specific act measurably and significantly lowers circulating cortisol within 20 minutes.
Finally, we deploy highly targeted evidence-based supplementation to reinforce the shutdown. The administration of 200 to 400 milligrams of magnesium glycinate exactly 30 minutes before your intended sleep time is a profoundly powerful, scientifically validated intervention.
It is vital to note the specific formulation, glycinate. Unlike other common forms of magnesium, such as magnesium oxide or citrate, which primarily act as laxatives, the glycinate formulation possesses the unique biochemical ability to efficiently cross the blood-brain barrier.
National Institutes of Health data conclusively demonstrates that this specific molecule actively binds to calming GABA receptors deep in the brain, directly and chemically downregulating the central nervous system and dropping nocturnal cortisol levels by up to 39%.
It chemically mandates the systemic relaxation and blood pressure drop that your rumination is attempting to prevent.
To synthesize this vast amount of dense clinical data, we must clearly outline the definitive, non-negotiable, heart-safe evening routine. It is a precise chronological blueprint meticulously designed to engineer your cardiovascular survival.
Dinner must be completely finished by 7 o'clock, utterly eliminating the massive hemodynamic conflict of late digestion and preventing vagal nerve stimulation.
By 7 o'clock, exactly 8 ounces of electrolyte-infused water, using potassium and magnesium, is consumed to permanently optimize blood viscosity and prevent nocturnal clotting.
At this exact time, if explicitly approved by your physician, your strictly timed antihypertensive medications are administered to combat the early morning pressure surge.
At 8 o'clock, a strict, zero-screen, low-stress, dedicated wind-down protocol begins. You utilize the 4-7-8 breathing technique and magnesium glycinate supplementation to aggressively halt cortisol production.
While the absence of blue light allows your pineal gland to flood your system with vascular repairing melatonin.
By 9 o'clock, the physical environment is rigidly secured at precisely 18 to 22 degrees Celsius to prevent thermal stress.
And by 10 o'clock, you are asleep, strictly positioned on your side, utilizing a body pillow to flawlessly protect the physical geometry of your airway and prevent hypoxic crises.
As we conclude this briefing, I want to deliver a message rooted not in fear, but in profound clinical reality and deep biological respect for the human machine.
The aging human body is not a fragile, failing piece of equipment simply waiting to expire.
Even at 75, 80, or 85 years old, your cardiovascular system possesses an extraordinary innate biological capacity to heal, to adapt, and to maintain its structural integrity.
But it can only execute that miraculous repair cycle if we actively, consciously remove the silent, highly destructive nocturnal stressors that constantly and mercilessly assault it.
Implementing this highly rigid, disciplined routine is not about chasing some abstract concept of modern wellness. It is the hard, clinical reality of extending your lifespan, preventing catastrophic cardiovascular events, and fiercely maintaining your physical independence in the final decades of your life.
Which brings us to a final, vital concept that every single person listening to this must deeply consider tonight. We have spent an hour systematically deconstructing these deeply ingrained habits, and a highly disturbing, undeniable pattern emerges.
Consider the deeply ingrained comforts of modern senior living, consuming heavy, indulgent evening comfort meals in a recliner,
Utilizing hyper-efficient climate control systems to create unnaturally warm, cozy bedrooms.
demanding endless, highly stimulating on-demand news and entertainment via brilliantly backlit screens while lying in bed.
And strictly avoiding fluid intake to ensure perfectly uninterrupted sleep. We must ask ourselves, how many of the very comforts we associate with a relaxing, well-earned retirement are actually inadvertently engineering the perfect biological storm against our own longevity?
You must rigorously, relentlessly, and honestly audit your own invisible evening routines starting tonight.
That rigorous audit of your evening behavior is the absolute first step toward true physiological autonomy and survival. But it must be paired with responsible clinical oversight.
Which leads directly to our mandatory medical directive.
The protocols, the biochemistry, and the clinical data discussed in this deep dive represent highly advanced cardiovascular research and complex physiological analysis. However, no listener, under any circumstance, should ever alter the timing, the dosage, or the implementation of any prescribed pharmaceutical medication, especially powerful antihypertensive drugs, without the explicit, direct, face-to-face consultation of their primary care physician or cardiologist.
Your specific biology, your renal function, and your pharmacological profile are entirely unique, and these potentially life-saving adjustments must be managed exclusively within a strict, monitored clinical relationship.
Take this data, schedule the appointment with your doctor tomorrow, and protect your heart.